It is my honor and pleasure to kind of introduce this last full session. This is our updates and deprescribing research. And this session is going to be led by two fabulous teachers. Amy Linsky. Amy is an associate professor at the Boston University School of Medicine and also an investigator at the VA Boston's Choir Center. Kristen Zimmerman is a pharmacist and an associate professor in the division of, pharmaceutical outcomes and policy?
Yeah, pharmaceutical outcomes and science.
Pharmaceutical outcomes and science at Virginia Commonwealth University. In addition to their official titles, they are like rock stars of deprescribing sort of education, as well as science and research. And they have given this talk, or previous versions of this talk in previous years, which was so great. Everyone's like, we need to have you come back. So we're so delighted that they are coming back. And I can't, like I said before, I just can't wait to see what kind of fun stuff you have today. So thank you.
Great. Thanks, Mike, for having us back again. Maybe we set the bar a little too high last year, but we'll see where it goes. So again, we're going to talk about some updates in deprescribing research appropriate to the locale. The theme this year is Deprescribing Goes Hollywood. So there's no conflicts of interest. The views are those of ours, not of our employers. And we didn't update our lit search last night, so the updates go until about a month ago. So there's 5 objectives for the talk today. The first is talking about some deprescribing opportunities, then some electronic deprescribing tools. We're then going to describe 2 patient-centered interventions, talk about the influence of patient perceptions. Finally, we will rethink a common deprescribing scenario, with the ultimate goal to make deprescribing famous. So some abbreviations, many of these will look quite familiar to the audience. The 4th one down, DRX, is deprescribing. We use it as shorthand primarily for space saving on our slides. So the rest are probably pretty familiar. All right, so to start it off, let's talk about some deprescribing opportunities. So this first one is going to be looking at diabetes overtreatment in long-term care. Specifically, looking at overtreatment, potential overtreatment, and undertreatment. And then seeing whether, and the rates of appropriate medication modification, and identifying factors that were predictive of continued overtreatment. So what did the authors do here? So this was a retrospective cohort of admissions to VA nursing homes from January of 13 to December of 2019. The patients were 65 and up, all had type 2 diabetes, and their first A1C value had to be drawn at least 24 hours after their admission. And this A1C value then becomes the index date. They then took a look at the glucose-lowering meds that were prescribed prior to that A1C value to create 5 cohorts based on those meds, mutually exclusive and in some essence escalating in terms of like intensity of care. So they could be on no glucose-lowering meds, they could be on just metformin, they could be on other glucose-lowering meds. Mostly this ended up being driven by sulfonylurea use, any short-acting insulin use, and then any long-acting insulin. So they then took those cohorts, those medication-based cohorts, combined them with the A1C to create their primary initial grouping of treatment appropriateness. So overtreatment was A1C less than 6.5 and any insulin use. Potential overtreatment was an A1C less than 7.5 with any insulin, or an A1C less than 6.5 and taking any glucose-lowering meds other than just metformin. Potential undertreatment, because it does still exist, was an A1C greater than 8.5 and no glucose-lowering meds. The primary outcome was continued overtreatment, and this was assessed by looking at the meds at baseline and then looking at the meds about 1 to 2 weeks after that index A1C value. So how did the population look? There was about 7,500 subjects in the study. Pretty typical VA population, so mostly older men. But you can see here that about 2/3 had an A1C less than 7.5. Notably also, more than half the population was taking long-acting insulin. So in terms of the cohorts, or the initial cohort of their medication treatment appropriateness, so about 17% of the group was classified as overtreated, with an additional 23% as potentially overtreated, with a scant 0.6% in that potentially undertreated group. So what happened to their meds from baseline to that follow-up 1 to 2 weeks later? So in blue, you can see that is when their meds were de-intensified, gray is nothing really changed, and red is their meds were intensified. So for that primary outcome of continued overtreatment, 73% of the overtreated group had continued overtreatment, and 81% of the potentially overtreated group had continued overtreatment. Perhaps worse is that there was also intensification of their glucose-lowering meds in these groups. So what were some of the factors that were predictive of continued overtreatment? It was more likely if in subjects taking long-acting insulin or with prior hyperglycemia. And it was less likely if there was severe functional impairment. But what I think is most interesting is that there was no impact from prior hypoglycemia. And about a third of the population had a sugar less than 70 in the time prior to that index A1C. They also saw that age and comorbidity did not impact continued overtreatment. So is deprescribing diabetes meds in long-term care mission impossible? We're seeing that it's still pretty common, and this actually aligns with work that we presented a few years ago by Josh Niznik and his colleagues, where deprescribing or de-intensification of diabetes meds was not very common, and they also saw that long-acting insulin was predictive of not de-intensifying. That also further is that hypoglycemia and increased medical comorbidities do not foster de-intensification. So what can we be doing to make deprescribing more possible in routine care? So let's move to our second objective. And I'm going to talk now about 2 different electronic deprescribing tools. So the first one is MedSafer, where we actually presented this last year, and the original MedSafer was a cluster randomized step wedge trial in 11 Canadian acute care hospitals. Patients were 65 and up, getting 5 or more usual meds, and they did show that the intervention reduced the proportion of patients with at least 1 PIM at discharge. Further, deprescribing was not inherently harmful. So now we bring you MedSafer, the sequel. And this time it was looking at the feasibility, applicability, and effectiveness of MedSafer in long-term care. So this happened at 2 long-term care units at a single Canadian academic geriatric center of care. There was standard quarterly medication reviews in November of 2018, and then there were these MedSafer enhanced QMRs in January of 2019. The study team did chart review to obtain demographics, comorbidities, lab values, and meds, and then they assessed the med list before and after each of the QMRs. And then they calculated deprescribing rates as the decrease in the number of meds per resident pre to post QMR. So the intervention itself, in terms of MedSafer, is a clinician deprescribing report that prioritizes deprescribing high-risk PIMs, intermediate risk PIMs, and PIMs of little added value. In this feasibility study, the study team actually created the reports and gave them to the QMR team. So the population, there was 55 residents, a little bit older, a bit more female prevalence here. And you can see at baseline about 15 meds per resident. So in terms of what did they find with MedSafer, they identified 208 medications with clear deprescribing opportunities, but only 12.5% of those were deprescribed. When looking at it by the number of residents, nearly all residents had at least 1 PIM identified, and 65% had a low to medium risk PIM deprescribed, and about a third had a high-risk PIM deprescribed. Now, in the original MedSafer in an acute care hospital, it was more about 55% of patients who had PIMs PIMs identified had it deprescribed. In comparing the MedSafer enhanced to the standard QMR, they did show that more meds per resident were deprescribed with the MedSafer enhanced QMR. And some of the reasons for deprescribing were little added benefit, reduced resident life expectancy, and overly tight control of diabetes. So you're going to see this over-treatment of diabetes theme coming back a couple of times. So the second study I want to talk about with respect to electronic deprescribing tools was entitled Less Pharma. And this was looking at PIMs in ambulatory adults, 75 and up, and determining the feasibility and GP acceptability of multiple different deprescribing support tools. So this was a prospective longitudinal study that took place in primary healthcare centers in Spain from September of 2019 to November of 2020. Patients had to be 75 and up and taking 10 or more chronic medications. Their primary outcomes were the number of PIMS per patient, the proportion of identified PIMS that GPs agreed were worth trying to deprescribe, and then the proportion of identified PIMS that were actually deprescribed in the subsequent year. So their intervention is called Check the Meds. It looks relatively similar to MedStopper for those who are familiar with that one. And it's an online deprescribing tool that applies criteria from Beers, Stop, Priscus on the electronic platform itself. Now, most people here are probably pretty familiar with Beers and Stop. Priscus is a German-derived criteria list, looks pretty similar to these other lists. And Lescron is also was developed in Spain, again, pretty similar. So there's these multiple tools and lists to identify PIMS. The Check the Meds incorporates patient data, labs, comorbidities, and meds, and then identifies PIMS and creates a deprescribing proposal. So for this study, the research team took those deprescribing proposals, met with the GPs for each of the patients, and discussed the deprescribing proposals. If the GP agreed that the identified PIM was actually potentially inappropriate, they would then attempt to deprescribe it in the subsequent 12 months. So they identified 168 patients, average age of about 82, a little bit more than half female. At baseline, they were taking 12 meds, and the intervention identified nearly 4 PIMS per patient. So that equates to about 2,000 medications across all the patients. And using any of the tools, about a third of those medications were identified as potentially inappropriate. But only a little bit more than half did the GP agree were inappropriate. And in terms of some of the reasons that they gave for why they weren't inappropriate or that they weren't going to try to deprescribe it, that the medical condition still needed this treatment, that they had tried deprescribing it in the past, or something that I find quite interesting is that somebody else was prescribing it. Ultimately, just about 17% of identified PIMS were deprescribed in that subsequent year. So what if we look at the different tools? There was 4 different elements there. So we can see here that Lescron and Beers actually identified more PIMS relative to the Stop and Priscus criteria. But with respect to agreement by the GPs, there was actually more agreement for those PIMS identified by Beers and Priscus, and ultimately a higher proportion of the identified PIMS that were deprescribed came from those from Beers and Stop, the 2 more popular ones that we know. So we know that complex electronic tools can identify the usual suspects that cause problems. But ultimately, clinicians aren't always agreeing with what they are, and this varies based on the criteria. Furthermore, translating the identification and agreement into actual deprescribing remains difficult. So how can we easily identify and deprescribe the usual suspects that can cause harm?
What a classic movie to lead off with, Amy. Love The Usual Suspects. But I can't help but wonder in these evaluations if what might help generate some more deprescribing would be including more of the patient, so more of a patient-centered intervention, which is a perfect segue into our next section where I'll describe 2 patient-centered interventions. The first intervention I want to describe is the SHED-MEDS trial, which evaluated the efficacy of a patient-centered deprescribing intervention among hospitalized older adults who were ultimately discharged to a post-acute care facility. This randomized controlled trial included patients aged 50 and up, admitted to an academic medical center, taking 5 or more pre-hospital meds, who were ultimately discharged to a post-acute care facility after hospitalization. This trial assessed medication count, PIMS, DBI, and adverse events at 3 key time points: at hospital discharge, at PAC facility discharge, and 90 days post-PAC discharge. The intervention itself included actions at 2 levels of care, initiated in the hospital and continued throughout PAC facility stay. In the hospital, the study team conducted a comprehensive medication review to identify and evaluate medications for potential deprescribing, and then brought their findings to a meeting that was conducted with the patient or the patient's surrogate during the hospitalization. Those findings were then forwarded on to the patient's outpatient provider and ultimately to the inpatient team, who had the final say in implementing any deprescribing actions. Upon transfer from the hospital to the PAC facility, the study team provided a copy of the hospital discharge medication list and the deprescribing recommendations to the PAC facility. The study team also monitored weekly any deprescribing interventions and the medication list at the PAC facility, and upon discharge from the PAC facility, provided that discharge list and any ongoing deprescribing recommendations to the patient's outpatient provider. And this intervention was compared to usual care, so a comprehensive medication review, but just to identify the best possible medication history only. And so if we look at the population included in this evaluation, it was predominantly patients in their mid-70s, largely community dwellers. Rates of cognitive impairment were somewhere around 20%, and no notable differences at baseline between control and intervention groups as it relates to things like hospital length of stay or pre-hospital medication number. But I did want to point out that median pre-hospital medication number was about 16. So to me, that says that there might be some room here to potentially identify PIMS and subsequently deprescribe, because that's a pretty solid medication number. So when we look at the intervention compared to control, we see a reduction in medication number as well as PIMS at 2 of the 3 key time points, at PAC facility discharge and 90 days post-discharge. And those 2 time points make a lot of sense. It makes sense that we didn't see a reduction at hospital discharge, as the turnaround time from enrollment to discharge was only about 2 days. So not a lot of time to generate deprescribing. So it totally makes sense that that PAC facility stay and post-discharge from the PAC is when most of that deprescribing happened. I also find it pretty interesting in looking at the median medication number between these groups differs by about 2, and PIMS also differs by about 2. So I can't help but wonder if those medications that were ultimately deprescribed were in fact PIMS. The evaluation also found that intervention reduced DBI at the 3 key time points, and by not too shabby 0.3 to 0.6 points. And importantly, there was no difference in overall adverse events or adverse withdrawal events. So I want to spend a little bit more time talking about this meeting with the patient or the patient's surrogate that took place in the hospital, and I'll pull some data from an associated study that was also published this year. So this meeting with the patient or the patient's surrogate lasted about 30 minutes, and they were generally conducted with the patient alone, and the study team made a median of 9 medication deprescribing recommendations per patient. In discussing those recommendations with the patients generally agreed with about 5 of those medication deprescribing recommendations. Where there was the greatest degree of agreement between the study team and the patient was for medications like antipsychotics, antacid GERD meds, antihypertensives, and diabetes meds. Where there was the least amount of agreement between the patient and the study team was with vitamins and supplements, which is a theme you'll hear again throughout our talk today, and also with depression meds. So now that we've talked about an intervention on the inpatient side, let's transition to the outpatient setting with the COFRAIL trial. So COFRAIL sought to examine the effects of family conferences on outcomes in frail community dwelling adults with polypharmacy. So the COFRAIL was a cluster randomized trial that included a number of primary care practices in Germany and sought to target frail community dwelling older adults aged 70 and up taking 5 or more medications. The primary outcome of this evaluation was hospitalizations within 12 months, and the 2 secondary outcomes were medication number and PIMS. The intervention first included a series of training sessions for GPs on how to conduct family conferences, but also included some information on case-based deprescribing recommendations and how to recommend non-pharmacologic alternatives during those family conferences. Following baseline data collection, GPs subsequently held 3 family conferences at baseline, 3 months, and 9 months. Those family conferences, much like you might guess from the name, included not just patients, but also family members and caregivers, and they lasted anywhere from about 30 to 45 minutes. So after those family conferences were complete, final data collection took place at 12 months. This population was predominantly patients in their mid-80s, largely patients who had mild to moderate frailty, And one thing I want to point out, or two things I should say, is the number of hospitalizations in the 6 months prior doesn't necessarily indicate at baseline that this was a high utilizer group in terms of hospital visits. When we look at median medication number as well, one thing you might notice is that here the median med number at baseline was 9, so potentially a little bit less room to maybe subsequently identify PIMS and subsequently deprescribe compared to what we saw in shed meds, where we saw about 16 pre-hospital meds. So ultimately, at the end of the intervention, about 2/3 of patients had had all 3 family conferences. Despite this, there was no significant difference on hospitalizations at 12 months. But again, that might be because this wasn't necessarily a high utilizer group at baseline. They did show a reduction in both medication number and PIMS at 6 months, but not at 12 months. And again, when you look at the difference in median number and the number of PIMS, differs by about 1 medication and 1 PIM. So again, I can't help but wonder if that reduction in medication number is due to a decline in the number of PIMS. So does this mean that for deprescribing to occur in this type of setting, we need the perfect storm, a great sort of New England throwback? So what do I mean by that in terms of the perfect storm? Well, if we think about both of these interventions, they're both very patient-centered, but they're also both relatively pretty resource-intensive. When we look at the shed meds evaluation, we see a more robust effect and perhaps a little bit more sustainable throughout that post-discharge period, compared to Cofril, where we didn't see a clear demonstration of that effect, particularly at the 12-month time point. So I can't help but wonder here if the sentinel event of hospitalization in shed meds is really what created that perfect storm and spurred that engagement on behalf of the patient, but also the outpatient team as well as the inpatient team to really ignite and facilitate deprescribing here. I also can't help but wonder if it's sort of due to the pre-hospital med number of 16 versus 9 that led to some of those differences, of course, in the interventions. So another good segue into how does this all tie in to patient perceptions in regard to deprescribing. So I want to turn now to a pair of evaluations that sought to examine how older adults make deprescribing decisions. And both of these evaluations focus on older adults. One focuses on older adults taking 10 or more medications of any type, so prescription as well as non-prescription products. And the other focuses on older adults taking 10 or more non-prescription products. Now, both of these trials utilize semi-structured interviews and qualitative analysis of a card sorting activity. So patients underwent an initial visit where they were interviewed to ascertain their medication list. Following the obtainment of the med list, patients then verified the list, and medication cards were created for every single prescription and non-prescription medication on that patient's list. At the second interview, patients were then asked to sort those cards, aka medications, into a series of piles. And those piles included medications that they wanted to talk about stopping, labeled here as stop, medications that they were unsure about or had other plans for, ultimately labeled by the study investigators as lowering the dose or lowering the frequency, or medications that patients wish to continue. When we look at both of these study populations, we see a couple of pretty unique things. We see that this patient population is predominantly white and really quite good health and has a really high level of baseline education, right? So it may not necessarily be the patient populations that we may be treating in practice or that we may be targeting with all of our deprescribing interventions. So I think that's one very interesting thing about this pair of evaluations. The other thing I want to point out is some of the medication data. A really high rate of medication number, right, in both of these interventions. So you'd think that there's some potential room to consider deprescribing here. But there's a really high proportion of those medications in both of these evaluations being non-prescription products. So in the 10 or more medications of any type evaluation, more than half of those medications were non-prescription products. In the 10 or more non-prescription product evaluation, obviously there's a lot of non-prescription products, but most of those non-prescription products, almost 3/4 of those, were herbals and supplements. So a relatively low proportion of patients using OTCs like NSAIDs or antihistamines, for example. So in terms of deprescribing preferences, in patients taking 10 or more meds of any type, they were pretty open to deprescribing. About 70% of patients had some interest. It equated to about 2 medications per patient that they think about stopping. But what I think is more interesting is what medicines patients sorted into what buckets. And one of the things that we see is that in this evaluation, the medications that they were most interested in stopping out of prescription versus non-prescription products was prescription-based products, with a very strong preference to continue their non-prescription products. When we look at patients in the 10 or more non-prescription product evaluation, we see a somewhat similar trend, but here we see a strong preference to continue both prescription as well as non-prescription products. So this might represent that there's some differences in how we value medications in these two types of patients, or some differences in the belief structure of patients who take more or predominantly non-prescription products versus a combination of the two. Another sort of interesting little nugget that the study authors sort of tossed in is that in patients who wanted to continue their non-prescription products in the latter study, patients generally thought that those medications were working and had a relatively low risk of causing harm. So there's certainly some appeal here of continuing non-prescription products. So given this appeal of non-prescription products, I'm going to insert a really good dad joke in an ode to my husband. Amy, do you have any studies that can supplement this?
I will do my best to follow up on that. But I do get to actually come back and talk about another diabetes study, so something that I'm quite interested in. And in this one, it's looking at perspectives of older adults with type 2 diabetes about discontinuing or de-intensifying their diabetes meds. So this recruited subjects from 3 academic affiliated clinics, primary care, diabetes, and geriatrics, from January to June of 2021. The patients were all community dwelling, 65 and up with type 2 diabetes, needing to take at least 1 diabetes med and have an A1C of less than 7.5. There were 2 components to the study. The first was a more traditional qualitative study with individual interviews and then qualitative coding methods to identify themes. And then at the end, as part of each interview, they also posed 3 hypothetical diabetes deprescribing scenarios for reasons for deprescribing, such as poor health status, limited life expectancy on the order of years, and high risk for hypoglycemia. There were 24 subjects, and you can see here that at baseline they were taking 11 medications, 2 diabetes meds, and 58% of the study group was taking a high-risk hypoglycemia med. So what were some of those themes? Well, first was fear of losing control of diabetes, that if they de-intensified those medications, that their sugars would go up, they'd have worse health outcomes, and they really just didn't want to have those happen. But balancing that was the benefits of taking less medication. There might be fewer adverse drug events, and then just the general burden of taking medicines, doing insulin or finger sticks, and so there was also positives being seen to de-intensification. The third theme was anchoring to their current diabetes treatment, and this was made up of ideas like unrealistic expectations of the benefits that they would get at this point from their diabetes meds, and also a lot more difficulty to adjusting their glycemic targets. And I think about when we start medications, especially for diabetes, although probably for many conditions, we often drill into patients like, you need to take this, you need to take it exactly as prescribed, you need to take this probably for the rest of your life, and we don't ever set up that foreshadowing that things might be able to change, and so this kind of comes as a surprise when we bring it up again later on. And then the fourth theme that might help with that was the influence of a trusting patient-provider relationship. And a lot of the subjects here were quite interested in having those conversations with their clinicians and understanding the rationale and the scientific evidence behind de-intensification. Now, what if we look at those scenarios, those hypothetical deprescribing scenarios? How palatable were they? So that you can see the 3 scenarios here, and then positive, ambiguous, or negative responses. And what I find the most interesting is that when framed around limited life expectancy, people didn't like it, like really didn't like it. But when you flip it and look instead at high hypoglycemia risk, it was much more acceptable. And so when we think about then in terms of deprescribing, taking the patient perspective into account is what's going to be necessary. That in well-educated patients with good health status who are taking 10 or more prescription or non-prescription products, we saw a low preference to deprescribe those non-prescription products, which also in SHED meds, that there was also that disinterest in stopping those supplements and non-prescription products. There was some preference to deprescribe other prescriptions in patients who were taking more of them. What I find really interesting is the messaging matters, right? So we saw here a preference for discussion of risk rather than life expectancy, similar to some of the stuff that Tim Anderson was presenting earlier this afternoon, and that Ariel Green spoke about last year. And that when we frame things around life expectancy, it doesn't really get a good reception. But talking about immediate risk is a lot more open to communication. And so we see that in order to move deprescribing forward, we really need to align the clinical decision making with patient perspectives. So let's come to our last primary objective for this talk, which is to rethink a common deprescribing scenario. And I know you think it's going to probably be diabetes, but we're actually going to pivot here to hypertension. And this study wanted to look at the impact of deprescribing antihypertensive meds on blood pressure and adverse events. So this study actually used data from the TONE trial, which occurred back in August of 92 to June of 94. So think like My Cousin Vinny, Mrs. Doubtfire, like to really get back into the frame of reference of what was going on back then. They recruited patients aged 60 to 80 who were taking just a single antihypertensive med. Now note that could be a combo of a diuretic and non-diuretic, but one pill for blood pressure. And they couldn't have had any significant cardiovascular events in the prior 6 months. They monitored these patients for up to 36 months, or if they hit one of the primary endpoints, which was a high blood pressure, treatment with antihypertensive medication, or the occurrence of a clinical cardiovascular disease complication. So what did they do in this trial? They stopped the meds. Everybody in the trial had their antihypertensive med deprescribed. But prior to stopping, they randomized subjects to interventions that might mitigate increases in blood pressure. So it was either a sodium reduction diet, weight loss, combined sodium reduction or weight loss, or usual care. Now note, if subjects were of normal weight, they would only be randomized to the sodium reduction or usual care groups. So in this population study, they ended up with about 1,000 subjects. Average age of like 65, so a little bit younger than some of our cohorts, but remember they recruited 60 to 80. And the baseline systolic blood pressures were in the high 120s, so pretty good. And again, taking just one medication. So here's what's happening with their blood pressures. This is just the systolic. And you can see on the far left is what happens before deprescribing. So this is when they had the kind of like a run-in period of lifestyle interventions. And in all of the intervention groups, the blood pressure goes down. That blue, solid, kind of flat line is the usual care group, which isn't surprising because nothing was changing. But then they stopped the meds, and these are the blood pressures from the time of deprescribing until 9 months. And the blood pressures all go up. But by how much? So in the usual care group, it goes up by 7.3 millimeters of mercury, 4.1 in the weight loss group, 4.4 in the sodium restriction group, and just 1.8 in the combined intervention group. Also of interest was what happened in terms of adverse events, though, because we're stopping blood pressure medicines. And there were actually 113 events across 95 subjects. 84 of those were symptomatic events, but 29 were clinical. And notably, about 1/3 of these occurred during the drug withdrawal phase, so right around the time of deprescribing, which isn't surprising because times of change is usually when things happen, but something to pay attention to. So given that we know that blood pressures are going to can go up when we stop the meds, despite some other lifestyle interventions, how does that fit into the big picture of deprescribing?
Oh, big picture, Amy. Funny you should ask about a big picture during a Hollywood-themed talk. What is a good Hollywood theme without ending in a trilogy? And so you might remember that the past 2 times that Amy and I have presented at this conference, we've included some data from the Optimize evaluation. So all the way back in 2020, we presented the original, which assessed the impact of deprescribing a single antihypertensive versus usual care in patients aged 80 and above who had otherwise controlled systolic blood pressure taking 2 or more antihypertensives at baseline. So essentially no difference in systolic blood pressure control as a result of deprescribing or other notable outcomes at 12 weeks, but there was an increase in systolic pressure of about 3.5 millimeters of mercury, and that'll be important as we'll see in a second. Last year, you might remember that we presented the sequel to this, which evaluated some exploratory analysis of differences on these outcomes by drug class or drug dose. Found some pretty interesting findings comparing calcium channel blockers versus beta blockers. And so this year, we want to present the threequel in the trilogy, which evaluated the cost effectiveness of this optimized intervention. So in keeping with the throwback theme, you might also remember this figure from when we talked about cost effectiveness evaluations last year, and we'll use it again this year as the sort of foundation for this evaluation. And so here, study authors used a Markov patient-level simulation, essentially to evaluate this effect of deprescribing that single antihypertensive versus usual care, again, in patients aged 80 and above, controlled systolic blood pressure, taking 2 or more antihypertensives at baseline, and evaluated this over a lifetime horizon, or a 20-year max, which totally makes sense, given that patients were aged 80 and above in this simulation. So authors expressed outcomes in terms of quality-adjusted life years and cost in pounds per QALY gained. So they used a 3-month cycle for switching between antihypertensive drug side effects, cardiovascular disease outcomes, or death. And the data for patient characteristics and mean blood pressure was modeled on that 12-week optimized trial data. So again, that 3.5 millimeter of mercury change following deprescribing at 12 weeks. And those differences were assumed to be maintained over the patient's lifetime. Data for ASCVD risk was calculated using the Q2 risk algorithm, and study authors here applied a multiplier of 1.5 in patients who had clinical ASCVD to account for limitations and risk calculators by age. And antihypertensive drug side effect data was modeled on the SPRINT senior data. And disutility application varied in terms of duration and application, which makes total sense, right, as the decrement to quality of life is going to be very different for something like an AKI from antihypertensive continuation versus an MI as a result of a blood pressure increase following deprescription of antihypertensives. So when we look at the results and we look at the base case, usual care was found to cost 4,700 pounds per patient and result in a gain of 3.4 QALYs. Deprescribing cost less, 4,500 pounds per patient, but we also saw less QALYs, only 3.3 QALYs gained. So certainly there was a reduction in antihypertensive drug side effects, you'd intuit that, right? But there was a notable increase in cardiovascular disease outcomes owing to that increase in systolic blood pressure that was seen in the optimized data that served as this model. So ultimately, usual care was determined to be the cost-effective strategy at about 3,000 pounds or like $3,700 US per QALY gained. So putting that into perspective, that is really, really cost-effective, right? When we think about the typical willingness to pay threshold of like 50,000 US dollars, like, so that is very cost-effective to not deprescribe that antihypertensive. So is antihypertensive deprescribing, this sort of scenario that Amy and I wanted to talk about, is this kind of up in the air when it comes to older adults? Well, if we look at the cost effectiveness evaluation, we see that deprescribing is not cost effective compared to usual care. Now, granted, right, there is some inherent uncertainty in the data on older adults that sort of served as the foundational model for this evaluation. This type of model really can't account for competing events that older adults might be more subject to, and it's based on that short-term 12-week data from the optimized evaluation. So if we kind of put that in perspective to the TONE trial, which Amy presented, data for at 9 months and all the way out through 36 months, I also find it really interesting in the sensitivity analysis. When might deprescribing become cost effective? Well, really in 2 scenarios. If the rate of serious antihypertensive drug side effects was to go way, way higher than what was modeled from the SPRINT senior evaluation, or if we somehow magically were able to create more QALYs as a result of antihypertensive deprescribing. I think both of those scenarios are less likely if the true change in systolic blood pressure is more representative of what was shown in the TONE evaluation, where the change in systolic blood pressure with usual care was like 7 millimeters of mercury, right, versus the 3.5 seen with optimized. Granted, they're different patient populations, they're off by like 2 decades of age, but it's just something to consider that we really may need to think about reconsidering antihypertensive deprescribing in older adults as a part of routine care. And so have we succeeded, Amy and I today, and us as a group of deprescribing researchers in the past year with this research, to make deprescribing famous? Almost. And we kind of say almost because there are so many more blockbuster research questions related to deprescribing that are left to answer. And we really hope, in keeping with the Hollywood theme, that some of you will go on to direct some of those blockbusters in the research that you do. So with that, Amy and I would really like to thank you, the adoring fans, We'd really like to thank USDEN, aka the Academy, for the opportunity to come and talk to you all today, and certainly for the work that you all do that served as the foundation for much of what we were able to present today. So this award actually goes to all of you, so thank you. So we're happy to take questions or reflections that folks have. I know many of the researchers are also in the audience, so if people want to share their reflections or their thoughts. Or everybody can just be like really tired from all of the amazing food and snacks today. That's also fair game. Yeah?
Just one other thing to make the deprescribing more cost effective is the cost of antihypertensives going up and up and up. And that may be the wish we get.
Sure, yeah. Does the cost of the antihypertensive medication increase? Is that the other variable to make deprescribing the antihypertensive more cost effective? Sure, yeah, definitely.